Hello and welcome to another emergency questions and answers for families in intensive care and intensive care at home. My name is Patrick Hutzel. I am your host of the show, and welcome to another live stream. Now, before we go into today's questions and answers, I should say, what makes me qualified to host an emergency questions and answers for families in ICU and intensive care at home? I am a critical care nurse by background, and I have been working in intensive care and critical care for over 25 years in 3 different countries, where I worked as a nurse manager for over 5 years. And I've been consulting and advocating for families in intensive care since 2013 here at intensivecarehotline.com. And I can very confidently say that we have saved many lives with our consulting and advocacy, and you can verify that on our testimonial section at intensivecarehotline.com. You can also verify it on our intensivecarehotline.com podcast, where we have done client interviews. I'm also the founder and managing director of Intensive Care at Home, and you can find more information at intensivecareathome.com. With Intensive Care at Home, we are sending our critical care nurses into the home 24 hours a day to mainly ventilated and tracheostomy adults and children. We're providing a genuine alternative to a long-term stay in intensive care, which also includes home BiPAP, home CPAP, without tracheostomy without ventilation, and also home TPN, PEG tube, PETch tube, nasogastric tube management, cough assist management, Hickman's line, PICC line, central line, port management at home. Now, also, I want to welcome the viewers that watch this on replay, but I also want to welcome, of course, the viewers that are here live on the show. Please type your questions into the chat pad so I can answer them, or connect with me live here on the StreamYard. And I have posted the StreamYard link in the chat box, and you can just click on that and connect with me live, and you can ask me questions live on the show, on camera or off camera. I don't mind. You know, some people are more comfortable by not showing their face. Doesn't matter to me. I'm here to answer your questions. We usually go for about an hour. I have to wrap this up in about an hour's time. I would also welcome, if you want to support the work that I'm doing, give the video a like, subscribe to my YouTube channel for regular updates for families in intensive care and intensive care at home, and share the video with other families and friends that have family members in intensive care. Raise awareness that there's help out there, and click the notification bell. Now, without further ado, let's look at the questions that have come in during the week. If you don't have any questions right away, that's all fine. I do want to start with ARDS and ICU management. With ARDS in ICU, we get questions quite frequently from readers and subscribers and clients. What is the standard treatment for ARDS patients in ICU? Now, let's start with some breakdown of definitions. What's ARDS? ARDS is acute respiratory distress syndrome, and it is a severe lung condition that requires intensive care management. In layman's terms, ARDS is also known as lung failure. So, treatment in ICU focuses on improving oxygenation, supporting organ function, and addressing the underlying causes, or underlying cause if there's only one. So let's look at the overview of ARDS treatment in ICU. First off would be mechanical ventilation. I've not seen any patients in ICU. You know, I've looked after hundreds, probably thousands of critically ill patients and their families over my career, and I've not seen any ARDS patients in ICU not being ventilated. So, you know, they're all ventilated with a breathing tube in the mouth or in the nose, and sometimes that progresses to a tracheostomy. However, generally speaking, ARDS patients are so unstable and unwell that a tracheostomy is contraindicated, because it would simply not be safe because of either high FiO2 levels, high oxygen levels needed to be compatible with life, The next contraindication would often be high PEEP, right? And also sometimes the nitric oxide treatment, and you can't really disconnect the ventilator for someone on nitric oxide because nitric oxide is toxic even in small doses. It can be therapeutic in small doses, but it can also be toxic for the environment. So let's look at mechanical ventilation in particular, what that looks like for ARDS. Low tidal volume ventilation, 4 to 6 mils per kilo of predicted body weight to reduce ventilator-induced lung injury. So why is that? Well, generally speaking, tidal volume for a ventilated patient in the literature is advised to be 7 to 10 mils per kilo. Okay, let's just, for argument's sake, an 80-kilo patient, 10 mils per kilo would be 800 mils per tidal volume per breath. With ARDS, it's 4 to 6 mils per kilo of body weight to reduce ventilator-induced lung injury. Why is that? So the reason for that is when you look at chest x-rays of ARDS, it's usually a complete whiteout, right? So what that means is the lungs are stiff, there's barely any gas exchange going on, i.e. oxygen can enter the body into the arteries through the lungs because the lungs are so stiff and there's secretions everywhere and there's a lot of resistance in the lungs, right? And alveoli are often collapsed, right? Alveoli is actually sort of the bubbles in the lung where the gas exchange is taking place. So by reducing actually the tidal volume ventilation, you're giving it a higher chance for some oxygen to enter the alveoli and exchange gas, i.e. oxygen entering the bloodstream and carbon dioxide going out of the body, right? That also ties in with high frequency oscillatory ventilation. That is often the low tidal volume ventilation is often supported by high frequency oscillation ventilation. Basically means you're giving low volumes, but at a high speed. It's like those high frequency oscillatory ventilation machines it's almost like a machine gun, tack, 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 with low tidal volume. And that can help, right, to improve oxygenation. Because one thing that you will see with ARDS is that patients can deteriorate very rapidly. Their oxygen saturation drops, their arterial blood gases look really poor. And that's why, patients deteriorate rapidly. Next, PEEP, positive end expiratory pressure, keeps alveoli open. We keep talking about alveoli here. Without the PEEP, alveoli won't stay open, and it improves oxygenation. Now, if all of that or some of that fails, another avenue here is prone positioning. Prone positioning basically means you can turn patients onto their stomachs, which can improve oxygenation by redistributing lung perfusion. So think about it. When you are turning someone on their tummy and you're putting head down, right, what that means is the lungs can expand, right? Whereas if someone is lying on their back all the time, the lungs can't expand, right? Because the lung expand to the back of the body too. So that I've seen also being very effective for some patients. Next would be FiO2 titration. FiO2 stands for fractured inspired oxygen. And that is basically the oxygen delivered from the ventilator, right? Keep in mind, room air, the air that you and I are breathing, is 21% oxygen. For many, if not for most ARDS patients, FiO2 is usually above 60%. Most of the time it's sitting at 100% with very poor blood gases. Other avenues for therapies for ARDS and lung failure are nitric oxide. I mentioned nitric oxide briefly a minute ago. Nitric oxide is a toxic gas. However, it can be used at very small doses to open up again alveoli and to reduce shunting, and that can also be very effective, especially in combination also with prone positioning. Other treatment options are epoprostenol or Flolan nebulizers. Again, that is usually unique to ARDS. All of that can help, right? Steroids on top of that can also help to reduce inflammation. If all of that fails, there's often a last resort, which is ECMO. What's ECMO? ECMO stands for extracorporeal membrane oxygenation, right? And it is used in severe refractory ARDS when ventilation and all treatment therapies that I've just mentioned now fail or are not enough to reverse the causes. Now, also, before we look at ECMO in more detail, you also need to look at obviously giving antibiotics if the ARDS is caused by bacteria, antivirals if it's caused by a virus, and antifungal if it's caused by a fungus, right? So, and you can find them out often by taking a sputum sample. You know, you would have seen during COVID, a lot of patients went into ARDS COVID induced, and that would have been caused by a virus. So let's quickly focus on ECMO. What is ECMO? ECMO, once again, is extracorporeal membrane oxygenation. It's basically a bypass machine. So what that means is venous blood, deoxygenated blood, is extracted from the body through a large vein, femoral vein, subclavian vein, for example, and then is running through a bypass machine where carbon dioxide is being removed and oxygen is being introduced into the bloodstream through the bypass machine, through the ECMO machine, and then is basically going back into an artery into the body. And, you know, that's how the lungs are bypassed, but the function of the lungs are being maintained, giving the lungs time to recover. And that is a strategy that can work. There are numerous risks for patients going on ECMO, you know, including blood clots, strokes, bleeding. You know, I'm not going into too much detail now. You know, obviously the time is limited for a patient to be on ECMO. It, you know, can't be, you know, for forever. You know, foreign body, that's basically a foreign body, a foreign machine, I should say, entering the body, and that is time limited. Next, other things that can help with treating ARDS in intensive care is fluid management. Generally speaking, a conservative fluid strategy to prevent pulmonary edema while ensuring adequate organ perfusion. So what that means is, for most ventilated patients, if not for all in intensive care, you would run a conservative fluid strategy. So what that means is you're always erring on the side of caution for not fluid overloading a patient, because if you're fluid overloading a patient and extra fluids enter the lungs, that makes it more difficult to wean a patient off the ventilator, right? And again, if you look at chest X-ray of ARDS, like I said, it's usually a complete whiteout, you know, and you don't need any extra fluids for lungs that are already severely compromised. Also, why is conservative fluid management mentioned in the same sentence then whilst ensuring adequate organ perfusion? If you're not giving enough fluids, then organ perfusion might suffer. The kidneys might not get enough fluids. The liver might not get enough fluids. The brain might not get enough fluids, you know. So you gotta weigh up how many fluids are enough, how many fluids are too many. Next, let's look at medications when someone is in ARDS, in ICU, ventilated. So to facilitate ventilation and reduce oxygen demand, you have to sedate a patient, often with midazolam/Versed, propofol, or Precedex, also known as dexmedetomidine. Those are the most commonly used sedatives in ICU, and you also need to give some morphine or fentanyl often to reduce pain, to minimize pain, right? And facilitate the ability to ventilate a patient, which can be very uncomfortable, very painful at times, right? Furthermore, why does it say to reduce oxygen demand? If you wouldn't sedate a patient, right, patients would be air hungry and they would potentially breathe against the ventilator because their lungs are shut down, more or less. Because the lungs are shut down, they would be air hungry and they would fight against the ventilator, right? Now, other things on top of sedation and opiates for pain relief, you could do a neuromuscular blockade, also known as muscle relaxants or paralyzing agents. Once again, that would be a last resort, trying to avoid that. But, you know, again, I have seen patients with ARDS going on neuromuscular blockades or paralyzing agents, right, to be able to facilitate ventilation and reduce oxygen demand. I'll give you an example why that can be used. So let's just say you have high sedation levels and high opiate levels, right? But you still need to turn a patient to wash their back to make sure they're not getting any pressure sores. You've got to change linen, you know, got to change their sheets. You might have to do a dressing change on someone's back, whatever the case may be. And when you turn patients on already 100% of oxygen, they might drop their SATs pretty quickly, their oxygen SATs pretty quickly, and that can be life-threatening. Because also part of it is that they're fighting against the ventilator when you turn them because it's so uncomfortable. So one way to manage that is with neuromuscular blockade or muscle relaxants or paralyzing agents, just illustrating the challenges of, you know, the hands-on work that needs to be done with ARDS patients. Next, I did mention that steroids is another option for moderate to severe ARDS to reduce inflammations. I talked about antibiotics, antivirals, antifungal medication. Vasopressors and inotropes are also something that needs to be something that might need to be added onto the mix. Most of the time it does, unfortunately. So what are vasopressors and inotropes? Vasopressors are basically vasoconstrictors that are constricting the blood vessels to centralize blood towards the heart to increase blood pressure. Why would blood pressure even go down in the first place? Blood pressure would go down because ARDS is an infectious disease. Often a septic picture follows, and a septic picture leads to often hypotension, meaning low blood pressure, dangerously low, where organ perfusion is at risk. If organs aren't perfused, the heart's not getting enough blood, the lungs are not getting enough blood, the liver, the kidneys, the brain, and so forth, which could lead to organ failure, right, increasing the risk of death or medical emergencies. By introducing vasopressors, you can maintain a better blood pressure, right, a blood pressure that's compatible with life, blood pressure that's compatible with organ perfusion. Commonly used vasopressors are phenylephrine, levofed, norepinephrine, epinephrine, vasopressin. Those are the names for those drugs in North America. In the UK and in Australia, you would call those medications noradrenaline, adrenaline, and vasopressin. There's also inotropes such as dobutamine, dopamine, milrinone being used for cardiac failure as well. What else needs to happen for ARDS in ICU? Treating the underlying cause, of course, addressing infections, pneumonia, sepsis, managing trauma or other conditions contributing or leading to ARDS, supportive care such as nutritional support via enteral feeding, deep vein thrombosis, DVT, and stress ulcer prophylaxis. Let's just hone down on both of them. So nutritional support via enteral feeding usually happens via a nasogastric tube. The challenge there can be that, you know, depending on the level of sedation that's being used and how much sedation opiates are being used, that the digestive tract might slow down because of the sedatives and the opiates. If the digestive tract is slowing down, then you could have a high chance of reflux. Your loved one may not digest the enteral feeds, leading to reflux, risk of vomiting, risk of aspiration, and so forth. So you got to monitor that. You got to monitor the reflux and the absorption, and then titrate feeds accordingly. Deep vein thrombosis and stress ulcer prophylaxis. Deep vein thrombosis is obviously a high risk for anyone that's immobile. An ARDS patient would be immobile. You manage that with anticoagulation such as heparin, Clexane, predominantly, also with either calf compressors or TET stockings. Stress ulcer prophylaxis. Most patients in ICU are at high risk to sustain a stress ulcer, or even worse, a gastric bleed resulting from a stress ulcer. The ways to prevent a stress ulcer is to start feeding early, nasogastric tube feeds, and also to give medications such as omeprazole, also known as pantoprazole, or esomeprazole, ranitidine. Right, those are medications that would be given, also known as proton pump inhibitors. And then lastly, physical therapy to prevent muscle wasting if feasible. Patient needs to have their joints being moved, their legs and arms being moved while they're in an induced coma. So, because if you're not doing that, the muscle wastage and the contractions can follow very quickly, and then the recovery is going to be so much more difficult. So I can't stress enough how important it is to get a patient back on their road to recovery as quickly as possible. Now, that pretty much sums up treatment for ARDS in patients in intensive care. Are there any questions in relation to ARDS treatment for patients in intensive care? If there are, please type them into the chat pad, or connect with me live on the StreamYard link here. If there are no questions to this particular topic, then I would like to move on to the next question that came in during the week. And the next question that came in was, what if 100% FiO2 is not enough for a ventilated patient in ICU? To a degree, it does tie right in with ARDS treatment for patients in intensive care. Having said that, if a patient in intensive care needs 100% of FiO2, it doesn't have to be related to ARDS, could be related to other issues as well. Could be a pneumothorax, right? Could be lung cancer, could be trauma, right, after a car accident. And there could be other issues, of course, could be pulmonary edema. There could be other issues, could be pulmonary fibrosis. There could be other issues leading to a patient needing 100% FiO2. So again, let's set the scene. 100% of FiO2, what does that mean? FiO2 stands for fractured inspired oxygen, and is being delivered on the ventilator for someone on a ventilator, either via breathing tube in the nose or in the mouth, either via tracheostomy through the neck, or it can also be 100% FiO2 can also be delivered on BiPAP or CPAP ventilation without a breathing tube or a tracheostomy, just with a mask. So again, to set the scene, room air, the air that you and I are breathing, is 21%, right? So if someone is on 100% of FiO2 on a ventilator, that means they're getting roughly four times the amount of oxygen that is consistent in room air. So that obviously illustrates how sick a patient or a client is. So what needs to happen for something like that? Always try to remedy the underlying cause, right? And also what is important to note, if someone is on 100% of FiO2, this is obviously a very critical situation requiring immediate interventions, right? Because you can't get any higher than 100%. You can't, right? You also need to verify that, you know, if let's just run a scenario. Let's just say oxygen saturation is 70%, right, which is dangerously low, right? You probably need to verify that with an arterial blood gas as well to make sure it is adequate before you're cranking up your FiO2, because too much oxygen could also lead to oxygen toxicity. So what can be done? Number one, increase PEEP or positive end expiratory pressure helps keep alveoli open and improves oxygenation. What is PEEP? PEEP stands for positive end expiratory pressure. It basically keeps alveoli open at the end of expiration, right? And so that the lungs don't collapse. Only needed when a patient is ventilated. You don't need that when you're spontaneously breathing. Next, simply to what I mentioned with patient on ARDS, prone positioning. Prone positioning basically means turn a patient on their tummy, head down, so that the lungs can fully expand, because when a patient lies on their back, the lungs can't fully expand, right? Also, by putting head down, there's a higher chance that the lungs can drain secretions just via gravity. Next, adjust tidal volume and respiratory rate. Low tidal volume ventilation, 4 to 6 mL per kilo, can reduce ventilator-induced lung injury while maintaining adequate ventilation. Again, this is not dissimilar to what I mentioned about ARDS treatment a minute ago. Low tidal volume with a higher rate can increase oxygenation. Next, recruitment maneuvers briefly increase airway pressure to reopen collapsed alveoli, right? So you could also potentially use a cough assist machine here, right, which we're using in the community for our intensive care at home clients quite frequently. Next, consider alternative oxygenation strategies, which is inhaled nitric oxide or epoprostenol. Again, I've mentioned that briefly when I was talking about ARDS treatment. Can improve ventilation perfusion BQ mismatch by dilating blood vessels in better ventilated lung regions, right? And again, similar to ARDS, high frequency oscillation ventilation may be considered in refractory hypoxemia. Once again, similar to ECMO, similar to ARDS treatment, ECMO can be used, right? If all ventilation strategies fail, ECMO provides oxygenation outside of the lungs. So if you want to know about ECMO, just go back to the part where I talked about ECMO for ARDS. It's explained there. And this video will go, you know, on YouTube after the live stream is over. You can watch it there on replay. Next, you need to check for causes of refractory hypoxemia. What does hypoxemia mean? Hypoxemia means low oxygen levels, not enough oxygen in the body. So what are those causes? I mentioned it in the beginning. Pneumothorax, air trapping in the chest may prevent adequate oxygenation. You can almost say that, you know, let's just say you have a ventilated patient and all of a sudden their oxygen levels reduce rapidly. You know, I've seen that patients end up with a spontaneous pneumothorax or have a spontaneous pneumothorax for whatever reason. That might come after some procedures, after line insertions, central line insertions in particular. But, you know, could be a number of reasons why a pneumothorax has happened. If a pneumothorax has happened, it needs to be treated with a chest drain, right, or pigtail, right? Also, hematothorax, right? Hemothorax can also happen. Lungs fill up with blood for whatever reason, and that can also cause increased oxygen requirements. Next, right to left shunt. Severe ARDS can cause non-aerated lung regions where blood bypasses oxygenation. Not dissimilar to what I explained earlier with ARDS, but again, this could also be caused by blood in the lungs or by fluid in the lungs. Right? It doesn't have to be ARDS. Pulmonary embolism can severely impair oxygenation despite mechanical ventilation. What's a pulmonary embolism? It's basically a blood clot in the lungs, shutting down parts of the lungs, causing, deoxygenation and hypoxemia. Lastly, ventilator-associated pneumonia, also known as VAP. An infection can worsen oxygenation. Now, also, ventilated patients in intensive care are at higher risk of a ventilator-associated pneumonia, and the sooner a patient in intensive care can come off the ventilator, the better. Very simple. Okay, so that pretty much covers that topic. Now, do you have any questions in regards to 100% FiO2 or going back to ARDS? Any questions in relation to that? Please type them into the chat pad or go to the StreamYard link and talk to me directly here. If there are no questions, then let's move on to another question that came in from Karen this week. And Karen says, "Hi, Patrick. Hi, Patrick. My dad was sent to the ICU for dialysis on CRRT machine to take off fluids. CRRT stands for continuous renal replacement therapy. It's basically a dialysis machine or a hemofilter that's basically replacing the kidney function. My dad had CHF, congestive heart failure, and his heart ejection fraction was at 30%. Ejection fraction basically means the contractility of the heart is low. Normal ejection fraction is about 50 to 70%. Sort of diminished ejection fraction is between sort of 40 to 50%, and the low ejection fraction is less than 40%, sorry. Less than 40%. Karen's dad had an ejection fraction of 30%, so pretty low, right? Why is ejection fraction so important? Ejection fraction in intensive care is so important because it basically refers to the contractility of the heart. If contractility of the heart is poor, then the pump function of the heart is poor, potentially leading to poor organ perfusion, right? Poor organ perfusion can lead to organ failure. That's why ejection fraction is so important. Karen's email continues. While at the hospital, they use Bumex. Bumex is a strong diuretic, basically increases urine output. Bumex is also known as Lasix or furosemide. And they drain his kidneys dry, which led him to be on dialysis. He ended up on vasopressors, initially 1 bag, and they couldn't wean him off it. Then they had to increase the vasopressors to 4 bags, and the nurse said he was maxed out on vasopressors. I feel like they killed my dad. And he had a low blood pressure that they said that kept getting low. Well, thank you, Karen, for sending that email, and I'm very sorry to hear about your dad's passing. And that's extremely sad, what's happened there. But let's break this down in more detail so that you can understand what's potentially happened here. First off, the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. Also, before I break down Karen's email in detail, what it comes down to here is, was this a real or a perceived end-of-life situation? Now, from the outset, you might say it was a real end-of-life situation because, you know, your dad couldn't be saved at this stage. But the question is, could he have been saved with the right treatment? That's something that I'm trying to break down here, because a real end-of-life situation is an end-of-life situation in intensive care where no treatment, no surgery, no medications, no fancy equipment, no nothing will save your loved one's life. A perceived end-of-life situation is, it's just that, it's a perception. That means a patient can receive life-sustaining treatment. If they don't receive it, then they might die, right? So we're trying to find out today, or in this email, was it real or was it perceived, right? So while at the hospital, they used Bumex, which is also known as furosemide Lasix, and drained his kidneys dry, which led him to be on dialysis. Yes, that could be a reality, because if you're giving too much furosemide or Lasix or Bumex and you're drying out the kidneys too much, your creatinine goes up, leading to kidney failure. So that is a theory that I can support, right? And then, you know, with his severe heart and kidney failure, and the way they manage his fluids and medications may have pushed his body beyond what it could handle. It may have, it may not have, because what have they done leading up to it? This is why it's so important that you as a family member get access to the medical records as quickly as possible. If you're not getting access to the medical records as quickly as possible, right, you are flying blind, especially if you're not getting a second opinion, right? So when I say you need to get access to the medical records, you do need to get access to the medical records, but then you also need to talk to someone who can interpret the medical records in real time, not when it's too late. You know, we are interpreting medical records in real time so that you can get that second opinion in real time, right? It's unbelievable how many families come to us when it's too late. You know, like Karen is coming to us when it's too late. Karen should have reached out when her dad was in ICU, so we, you know, were able to help her in real time. Anyway, so with congestive heart failure and the low ejection fraction, right, your dad's heart was most likely struggling to pump blood effectively to begin with. Using the Bumex / Lasix or furosemide, which is a strong diuretic, right, and a diuretic is basically increasing urine output, to aggressively remove fluids may have dehydrated him too much, so he lost too many fluids, which most likely worsened his kidney function and caused the low blood pressure, also known as hypotension. And this would have made it even harder for your dad's heart to pump blood to vital organs. If then the blood pressure drops too low, vasopressors like norepinephrine, dopamine, or epinephrine, or phenylephrine, or vasopressin, or dobutamine, milrinone are used to keep circulation going. But if they kept increasing his vasopressors or inotropes to maximum levels, which it sounds like that's what they've done, and he still wasn't responding or stabilizing, it likely means that his heart and circulation were failing. At that point, his body may not have been able to recover. That's the theory. But the question is, what was happening or potentially not happening leading up to it? You know, you haven't talked about, you know, what's your dad's medical history? We don't know any of that. You know, did he get into ICU early enough? You know, could they have treated him with fluids on the ward or at home? You know, this is what I'm saying. You know, there are some pieces in the puzzle that are not lining up and that are potentially missing, right? But, you know, I mean, anyone who's watched this blog for a while, how many videos am I making about where families come to us when it's too late? Don't come to us when it's too late, right? Come to us when the iron is hot, so to speak, when your loved one is in intensive care, because what you see in intensive care is not what you get, right? So the question remains, did they kill your dad or not kill your dad? I don't know, but we will find out when we look at medical records. Could his death been prevented? Again, I wouldn't know unless we look at the medical records and dissect the medical records in much detail and leave no stone unturned. Have they done an ultrasound of the kidneys early on? Have they done a CT scan of the kidneys? Have they done, to check the ejection fraction, did they do an ultrasound of the heart early on and a CT scan of the heart, right? So when did they find all of this out? Was there a delay in diagnosis, right? And if there was a delay in diagnosis, whose fault was it? Right? So, are there any questions in relation to Karen's email? If there are, please type them into the chat pad. If not, connect with me live here on the StreamYard link. We have time for another question. Well, the question that came in from Peter is from the UK, and you could argue is somewhat UK and NHS specific. For those of you who don't know what the NHS is, the NHS is the National Health Service in the UK. It's basically sort of the unilateral public healthcare system. Pretty much all hospitals in the UK are under the NHS, National Health System. So let's look at a question from Peter, which is a really good question, relevant question for families in intensive care. He says, hi Patrick, can a clinical need of organ donation for the NHS, the National Health Service, take part in the apnea test? And if not, would it be a legality or a code of practice protected by law, like brainstem death in the UK? Now, again, whilst Peter is asking a UK-specific question, the question really relates to other jurisdictions and English-speaking countries, and it's pretty much the same everywhere from my research. But in the UK, the apnea test is a critical component of diagnosing brainstem death, which also means that the patient would be legally dead, right? So diagnosing someone with brain death also means in most jurisdictions that they are legally dead. This test must be conducted by 2 senior doctors that are independent of each other, independent from the hospital, neither of whom can be involved in organ donation or transplantation. This requirement is part of the Academy of Medical Royal College's Code of Practice for the Diagnosis and Confirmation of Death, and ensures there is no conflict of interest. So your question has already been answered, right? So, which then leads to the second part of your question, can a clinical lead for organ donation take part in the apnea test? No, of course they cannot, just as I said. Clinical lead for organ donation works for the NHS blood and transplant department and promotes organ donation, but is not involved in the actual diagnosis of brainstem death. The Code of Practice prohibits doctors involved in organ donation from participating in brainstem death testing, ensuring the integrity of the process. That's a huge aspect of it all. You need to ensure the integrity of the process. Is this a legality or a code of practice? This restriction is based on the Code of Practice for the Diagnosis and Confirmation of Death, which was updated in 2008, which is the authoritative guidance in the UK. While not a law in itself, it is widely followed and considered legally binding in practice. As failure to comply could result in serious professional and legal consequences. Additionally, the Human Tissue Act 2004 governs organ donation and ensures that decisions regarding death and organ retrieval are made separately to prevent conflicts of interest. The latest guidelines, the Code of Practice for the diagnosis and confirmation of death in the UK, has been updated as of 1st of January 2025, so this is all happened in the last few months. This code continues to provide authoritative diagnostic criteria for confirming death, ensuring that all deaths are diagnosed and confirmed in an accurate, standardized and timely manner. Regarding the involvement of a clinical lead for organ donation in the apnea test, the updated code maintains that doctors involved in organ donation or transplantation should not participate in the diagnosis of death using neurological criteria. This separation is designed to prevent any potential conflict of interest and to uphold the integrity of the death diagnostic process. While the Code of Practice itself is not a law, it is considered authoritative guidance and it is widely adhered to within the medical community. Non-compliance with this guidance could lead to serious professional and legal consequences. Additionally, the Human Tissue Act 2004 governs activities involving human tissue, including organ donation, and emphasizes the importance of appropriate consent and ethical practices. In summary, a clinical lead for organ donation should not take part in the apnea test as per the Code of Practice to ensure ethical standards and to prevent conflict of interest in the diagnosis of death. Makes perfect sense. Makes perfect sense, but I'm glad you've answered the question. You've asked the question anyway. But what that's telling me is that you obviously have concerns that those guidelines are being breached and that someone who's quote unquote selling organ donation would have a conflict of interest in also diagnosing brainstem death. Right? I think that leads to a wider question. And it's probably the question that needs to be asked leading up to that question. When should brain death testing actually be done? Right? Let's look at that. Because I can't tell you how many families we have reaching out to us saying, oh, you know, ICU is telling us my loved one is brain dead, and then it turns out they're not. You know, when we go in for a second opinion, they talk about brain death, whereas there's no indication of brain death. Nothing. Zero. You could argue there's conflict of interest there straight away. Right? So let's look at when should brain death testing be done to begin with. Brain death testing should be conducted when brainstem death is suspected due to severe brain injury, which could be caused by cardiac arrest, traumatic brain injury, intracranial hemorrhage, or severe infection such as meningitis and encephalitis. According to the Code of Practice for the Diagnosis and Confirmation of Death, brainstem death testing should be performed under the following conditions, which also includes the prerequisites for brain death testing. Number one, catastrophic brain injury. A patient must have suffered a severe brain injury due to conditions such as traumatic brain injury, intracranial hemorrhage, i.e. stroke, subarachnoid hemorrhage, hypoxic brain injury after cardiac arrest, severe infection, meningitis, encephalitis. Number two, there should be no evidence of a reversible cause. The medical team must rule out conditions that can mimic brain death, such as hypothermia, temperature below 34 degrees Celsius, severe metabolic or endocrine imbalances, drug intoxication, including sedatives, anesthetics, or neuromuscular blockade. The patient must be on mechanical ventilation. The brainstem controls breathing, so the patient must be ventilator dependent. Right? Next, a clear diagnosis of brainstem dysfunction. There must be clinical evidence that the brainstem is no longer functioning. So when should the test be performed? Testing should be conducted as soon as all prerequisites are met and when it is deemed that brain function is irreversibly lost. There is no mandatory waiting period after the injury, but doctors must ensure that any potentially reversible conditions have been ruled out. 2 senior doctors, neither of whom are involved in organ transplantation, must conduct the test. Right? There needs to be absolute independence. Right? There needs to be absolute independence. But like I said, many families reach out to us and they say, "Oh, look, we've been told my loved one is brain dead," and then we finding no, that's not the case. So it's almost, when ICU teams are doing that, it's almost sort of, they want to create a narrative of negativity. They want to create a narrative of doom and gloom, right? And because of this narrative of negativity and doom and gloom, it's easier for them to create a narrative that your loved one is dying, without putting all the resources and efforts in to potentially improve your loved one's condition, improve your loved one's situation, and get them out of intensive care alive. I also believe I need to mention at this point that whenever, if you're watching this and you're faced with negativity, doom and gloom, you can buy into that, but you don't need to, right? And here is why you don't need to. The evidence suggests that 90% of intensive care patients approximately survive. So that means the odds are in your loved one's favor. So why should your loved one not survive? Assuming that the intensive care team is doing all the right things. Right? So don't get sidetracked by semantics, by wordplay, and find out what the meaning behind those words actually is. And is it hospital politics that by telling you about brain death and your loved one is not brain dead, that it's easier for them to argument for withdrawing treatment? Okay, so that concludes the topic about brain death testing. If you have any questions, this is sort of your last chance to ask a question. Type your question into the chat pad, or connect with me on the StreamYard link. I have about 6 minutes left before I wrap this up. 5 minutes left before I wrap this up. So here's your chance to ask some questions. Right, LinkedIn user says, fascinating statistics, Patrick, 90% of patients in ICU survive. Look, there are some differences in the statistics slightly from country to country, and also from diagnosis to diagnosis, right? So you will see differences. And in some countries, maybe the statistics are more like 70%, but that still means the odds are in your family members' favor. Also, for example, when you look at clinical pictures like ARDS, the survival rate is probably lower, the mortality rate is probably higher, so it depends a little bit on the diagnosis as well. But in any case, the statistics are what they are, and you always have to read between the lines, no matter where you are. Okay, so if there are there any other questions? If there are, please type them into the chat pad now. If not, I will wrap this up in a minute. I can only encourage you to, check out our respective websites, intensivecarehotline.com and also intensivecareathome.com. With intensivecarehotline.com, you will get consulting and advocacy for families in intensive care. Intensive care at home, we are sending our critical care nurses into the home for predominantly long-term ventilation and tracheostomy, but also BiPAP, CPAP ventilation, cough assist management, also tracheostomy care without ventilation, home TPN, home IV potassium infusion, PEG tube, PETch tube management, nasogastric tube management, Hickman's line, central line, PICC line and port management at home, and also palliative care at home. We are also providing level 2 and level 3 NDIS support coordination. And we are also providing case management for the TAC and WorkSafe in Victoria. So please reach out to us for all of that. If you are an NDIS support coordinator from another organization and you're looking for nursing care for your participants, please reach out to us at intensivecareathome.com. If you need a specialist NDIS nursing assessment or nursing assessment in general, we are also doing them, especially when it comes to the transition from hospitals to home, especially when it comes to ventilation, tracheostomy, anyone that's stuck in ICU long term, but also when it comes to a change in circumstances for NDIS participants. God forbid if their condition deteriorates, we are here to help you with rapid introduction of funding for NDIS participants in particular, but also with a rapid deployment of staff. And like I said, we can also do NDIS nursing assessments. We're also offering jobs for critical care nurses in the community in Sydney, Melbourne, Brisbane, Albury, Wodonga, Bendigo, Warragul. If you're ready for a change, if you're a critical care nurse, we want to absolutely hear from you. And because we offer exciting jobs here at Intensive Care at Home. If you're an ICU or ED consultant, we also want to hear from you. We are currently expanding our medical team as well. I would also welcome if you, before I wrap this up, if you're a subscriber, subscribe to my YouTube channel. If you support the work so you get all the updates, click the like button, click the notification bell, share this video with your friends and families, and comment below what you want to see next, what topics you want me to focus on. And that's today's session. Thanks again, everyone, for your participation and for your comments, and share the video. And I will talk to you again next week around the same time on a YouTube Live. And watch out for the updates that are coming during the week. Have a wonderful Sunday or Saturday, wherever you are. If you're in the US, it's still Saturday night. Have a wonderful weekend and a wonderful Sunday and a wonderful week. And I'll talk to you again during the weekend next week. Take care, everyone.